This episode of The Curbsiders is sponsored by the American College of Physicians. ACP is announcing its first National Internal Medicine Day on October 28th, and you can visit www.acponline.org/IamProud for further details.
Osteoarthritis globally is a huge problem, and the amount of money spent on managing musculoskeletal pain, for which OA and back pain are the leading causes, is more than cardiovascular disease, diabetes, and cancer combined.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect the official policy or position of any entity aside from possibly Cash Like More Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
This episode of The Curbsiders is brought to you in partnership with the American College of Physicians. ACP members can claim free CME and mock credit at www.acponline.org/curbsiders. Hey, Paul, do you think we should start the show?
Yeah, that feels right.
All right. Well, I'm gonna introduce our co-host in a second here, but first I'll tell you that tonight we are talking about osteoarthritis with returning guest Dr. Tuhina Neogi. She's a fantastic guest who's famous for being on our gout episode. Actually,
and exclusively that.
Exclusively that. So, Paul, before we get too far into this, can you tell the audience what we do on this show?
Sure. Hello, audience. We are the Internal Medicine Podcast, and we use expert interviews to bring you clinical pearls and practice-changing knowledge. We also get to know our guests at the beginning of the show. Everyone swears they don't skip past it, so maybe I'll even stop scolding at this point, but probably not.
I think so. I mean, I'm starting to get emails that say, like, stop scolding the audience, like, people listen, so...
Are you really?
Yeah, the Curbsiders are getting the emails. So.
I will continue the abuse. Yeah, no, please let me know, anyone who whines about that, and I'll just buck up is what I will tell them.
Well, on this show tonight, we go through the diagnosis of osteoarthritis, whether or not you need imaging. We talk about the pathophysiology, which I think most of you will find very interesting because it's definitely not what I was taught in medical school, and I think what is still widely believed about osteoarthritis. We talk about some of the etiology of the pain in osteoarthritis, and of course, we go through a bunch of different treatment modalities. We had a lot of questions from Twitter, and I should introduce joining us tonight on tonight's show is a first time. She's been a many-time writer, producer, artist on the show, but this is the first time being on air, and it is future physician Beth Garbitelli. Beth
Hi,
Garbs
everyone.
Garbitelli.
Yes, my nickname Garbs.
Right. So, Beth, thank you for joining us on the show, and thank you for putting together such great questions for Dr. Neogi.
Yeah, this was a fun topic to work on and one of personal interest because I have a very strong genetic predisposition for OA, so I'm getting ready for my hands to start generating any minute now. Probably surgery's out for me because of that, so...
Beth, did you want to give the audience a one-liner? Usually we let people give a one-liner the first time they're on air on the show.
Oh, shoot. I didn't even think about this before I was prepping. So I'm a medical student in my second year at Tufts University School of Medicine. Right now I'm in Boston, but I'm actually in Tufts Maine track. So I will be up in Maine for my clinical years next year in fourth year. I'm from Long Island / Vermont. We moved to Vermont when I was 12. I'm a huge Yankees fan, a big baker, and I love medicine.
Well, thank you for joining us on the show. Paul's going to tell us about the guests because we definitely we definitely have a lot of great stuff ahead for the audience.
Yep. Thanks, Matt. We are lucky to have Dr. Tuhina Neogi back again. As a reminder, Dr. Neogi is a chief of rheumatology and a professor of medicine at Boston University School of Medicine. She's also, in case that weren't enough, a professor of epidemiology at the Boston University School of Public Health. Dr. Neogi's research focuses on knee osteoarthritis and gout, pain mechanisms in osteoarthritis, and methodologic issues in rheumatic disease. Dr. Neogi is the recipient of the prestigious Henry Kunkel Young Investigator Award from the American College of Rheumatology, the Young Investigator Award from the Osteoarthritis Research Society International, and the Robert Dawson Evans Research Mentoring Award from Boston University School of Medicine's Department of Medicine. She also leads the CTSI's Research Career Support Program. Dr. Neogi serves on a number of national and international committees and organizations, including treatment guideline and FDA committees. She is one of the primary drivers of the current national guidelines for the treatment of osteoarthritis by the ACR, as well as, I believe, the gout guidelines, if I'm not mistaken. So we are extraordinarily fortunate to have her expertise with us as we talk about osteoarthritis.
Beth, do you have a pun?
No puns. I'm sorry. I'm punless.
Don't apologize.
This is the single greatest episode.
Tuhina, I want to start off. I'm going to give you the option to remind the audience about yourself. It's been, 80 some episodes probably, or 70 some episodes since you were last on. So can you please remind the audience who you are and what you're into?
Sure. Thank you for inviting me back. So I'm a rheumatologist and epidemiologist at Boston University School of Medicine and at the School of Public Health. And I do clinical research in osteoarthritis and gout primarily. As for my personal life, I enjoy music and going to a lot of concerts, reading, and I know you were asking about if I have any recommendations. I don't have any highbrow recommendations, but the last book I finished was a Joe Nesbo mystery. I think it was The Phantom, which I quite enjoyed. He's a popular mystery novelist, Norwegian. So a lot of the stories are set in Norway, but some are set in other countries as well.
One of our mentors, Uncle Bob Centaur, he recommended reading mystery books because as an internist, he told us we should think of ourselves as sort of like detectives when we're being a diagnostician. So I think the mystery works well for internists.
Absolutely. And same for rheumatologists. I feel that we are the detectives of internal medicine. When no one can figure it out, they call rheumatology.
That's 100% true. Yeah. Rheumatology and infectious disease get all the, I need someone smarter than me right now, please. And Joe Nesbo, he's the guy, he wrote the novel The Snowman that the disastrous movie is based upon.
Oh, yeah.
Oh, is there a movie about it?
There, you should. It's a fascinating movie to watch because it is just so astoundingly bad. Even though it's a lot of great people are involved in it, but there's a horrific movie for all the wrong reasons. If you ever find some free time on a Saturday,
wow,
it's probably worth a watch. I'm told that the books are spectacular. The movie is not.
Hate when that happens.
Beth, did you have any questions for Tuhina?
I would love to hear about any moments of awakening related to being a woman in medicine that you've experienced recently.
Well, I have been fortunate enough to become chief of rheumatology at my institution. And as a young-looking female visible minority, I'm in the minority of being a chief of a section. Earlier this year, we had a implicit bias training workshop, Bias Reduction in Medicine. And it was a 3-hour workshop led by a sociologist whose research is in implicit bias. I had to leave the session a little bit early, as did a couple of my colleagues, and the person leading the session turned to one of my colleagues remaining in the room and asked if the seat that was previously occupied by a certain individual was the section chief. And it turns out that seat had been previously occupied by the oldest Caucasian male in the room. So making the assumptions that we were just spending 3 hours talking about not making.
We'll eventually get there. It's kind of shocking though.
Oh man, pun intended.
Yeah, I think as painful as those stories are to hear, I think just hearing them over and over again just kind of underscores that there's still a long way to go. So it's always, even though it's awful that it's happened, it's helpful to hear about it. So thank you for sharing that.
Yeah, well, we all had a laugh about it.
Well, I'm so glad that you are the chief of rheumatology. That's fantastic. On a recent show, the Dr. Jagsy was talking about, one of our Women in Medicine shows was talking about, the chairs and department chairs and chiefs they need to get that percentage up. The percentage of women is low. It's something like 16%. So
yeah, absolutely. And she's done amazing research in this area and is really a role model nationally for bringing attention to these issues.
Yeah. Well, Paul, to follow that up, I mean, I'm sure you've got a great pick of the week for the audience that there's no way to easily segue to it.
Sure. Yeah, no, that was really nicely done. So I'm going to go from one uncomfortable topic to another. I'm going to recommend the movie Midsummer, the Ari Aster movie that is out.
God.
I just happened to see the director's cut last week, and it was spectacular. So in case you don't know, Ari Aster is the wunderkind. He directed the movie Hereditary, which is, I think, one of the most difficult movies I ever sat through. Like, it was extraordinarily well done, but it gave me a tummy ache. And Hereditary, similar. So he directs horror movies, but he directs horror movies about people who are sort of processing trauma. I think Midsummer is actually kind of a relationship movie. The long and the short is this group of young adults go to, I want to say Sweden for a ritual in a small village, and things get dark, but it's an incredibly controlled movie. Like the shooting, it reminds me of like Wes Anderson. Do you know Wes Anderson movies like the Grand Budapest Hotel, or like he's very famous for sort of framing these almost very picturesque shots. It's like Wes Anderson directing Nightmares is kind of Ari Aster. It's just everything's very beautiful and framed perfectly, and then he talks about these horrible kind of traumatic things. But it's again, I just need someone else to watch it so that I can talk about it with them. So if anyone would like to watch Midsummer for me, I would certainly appreciate it.
Well, I watched it without knowing anything about it, so I'm happy to chat with you offline, but I was kind of dumbfounded by what I was experiencing because I was not expecting that.
Yeah, I could do this for an hour and a half, so that's probably a terrible idea. But yeah, we should. We'll talk afterwards.
Well, Tuhina, I'm glad you saw it because Paul, I will not be watching that movie. I will
also not be watching that movie. The trailers alone had me like very freaked out.
I found it weirdly optimistic, and I'll let it go at that. I don't want to ruin the end for anyone, but it's not for the faint of heart for sure.
Beth, I want to give you a chance. It's your first time on the show. What do you have picks of the week for the audience?
Yeah, so I have two picks of the week. One's a film and one's an activity. And my film is sort of like the complete opposite of Midsummer in that it's incredibly heartwarming and life-affirming and not about a cult at all. Although I guess in some ways, those of us who love Mr. Rogers' Neighborhood is kind of a cult, but a really nice one. So I want to recommend Won't You Be My Neighbor, which is a documentary that came out, I believe, last year, but I only recently saw it a few weeks ago. And it's so moving, and it's just about the story of Mr. Fred Rogers and sort of where he came from and what informed the show. And I really, really enjoyed it. And it's a great thing to watch at the end of the week. If you've had a long week, you might shed some tears, but they'll be happy tears. And then in terms of the activity I wanted to recommend, as an avid baker myself, I wanted to recommend to everybody when this airs, I'm sure it'll be very deep in the fall. I wanted to recommend some fall baking since it's such an easy, nice, relaxing thing to do. And it's a great way to use up like apples or whatever, fruit you have around. And surprisingly, it's easier than you would expect. So I always tell people who are new to baking to try doing like a cobbler because you really can't mess it up. It'll come out great and it will taste great and you will feel so satisfied in having baked something delicious.
And Beth, are there any resources that you might plug or recommend? Any place that someone would go online and sort of investigate baking? You could look at my food blog at Vermont Kitchen. There we go. Thank you.
But really, in terms of other food resources, I love Serious Eats. Like, they have such great recipes, and they have this really awesome, like, pastry wizard, Stella Parks. She goes by Brave Tart on Instagram, and her recipes are foolproof. They really test everything on Serious Eats, and I love that it's not behind a paywall, so you don't have to have a subscription or something. They just have really great tested recipes that will work for you.
You're too generous. Say the name of yours again.
Mine's at Vermont Kitchen.
There we go.
Well, to transition us to the topic, Paul, my pick of the week is once again a jump rope. Hannah, first of all, We're going to be talking about physical activity as part of the treatment for osteoarthritis, and the great Hannah R. Abrams bought me a jump rope. I don't know why, as a birthday present, but she's just that fantastic. And I've been using it. And by the time this airs, I've been using it for about 2 months now. And it's been fantastic. So thank you, Hannah. And everybody get yourself a jump rope. Get out there. You got to do it.
So just to be clear, this is the thing with 2 handles and a piece of rope in between?
Well, it's usually a cord.
Okay.
Yeah.
And just for my education, and then we can move on. Forgive me, Dr. Neogi. What constitutes a good jump rope as opposed to a bad jump rope?
Well,
how would I know the difference as a consumer?
You want it to have some ball bearings, and it should have something like that implies it's really fast in the title. Like, I think this one's called like a ballistic speed rope or something like that. So,
okay.
Yeah.
All right. Great tips. Thank you. Mark your calendars. The American College of Physicians is excited to announce that October 28th, 2019 is the first annual National Internal Medicine Day. As the professional home for internists, the ACP established this day to recognize the unique contributions of the more than 300,000 internal medicine specialists and subspecialists who are united by commitment to excellence around the world. I am proud to be an internist because I get to make meaningful, multiple human connections every single day and impact lives in a way I couldn't otherwise do. So I take a lot of pride in my job, and I'm happy to be here to announce this event.
You also got to meet me.
It's not without its downsides.
And Paul, if I may take the liberty of saying, you're just so good at it. You say you're not a people person and you don't like talking to people, but people seem to really like you, Paul. That's why you are a national treasure. #national treasure. And speaking of hashtags, Paul, this is a chance for internists to tell their story. You can do it on social media, and you can tag @ACP internists or use the hashtags #IamProud and #National Internal Medicine Day. Also, if you want to enter a contest and win a prize, you can go to acponline.org/IamProud to enter the contest. Submissions that are put in before October 28th, you'll be eligible for their first round of prizes, which comes out October 28th. And then there will be 2 more rounds of prizes before June 2020. Answer the questions. What makes you proud to practice internal medicine? What recent patient experience made you proud to be an internist? And how is internal medicine unique from other subspecialties? So basically, just like brag about how awesome we are. The internal medicine, not us three. We are.
I mean, you could do that too.
You could do that too. So once again, National Internal Medicine Day, October 28th. This is the inaugural Internal Medicine Day, Paul. I'm very excited.
I can't wait to see what the prizes are.
And with that, I think Beth has a case from Kashlak Memorial Hospital. Tuhina, she'll be reading it to you, and then we're just going to ask you like thousands of questions about osteoarthritis.
Okay.
So I know in the tradition of curbsiders, we do a great job of using punny names for our patients that sort of tie in. And I'm apologizing outright for not having one for these cases as I was studying for renal. So I apologize for our nameless patient, but we're taking HIPAA very seriously for this episode.
I think you're now Paul's favorite person.
This is the best case I've ever read.
So our patient is a 67-year-old female. She presents with persistent aches and pains, especially in her hands. She also describes lower back pain and some stiffness in her legs. She felt this might be part of normal aging and has been controlling the pain with naproxen and rest, but notes that she thinks the pain is getting worse. She describes how she used to be quite active, but has had to slow down due to pain from exercising, and this has caused her to gain weight over the last few years. She has a BMI of 27 and a family history of heart disease. So I guess we could start with sort of what, if a patient like this comes into the clinic, what's the initial, physical exam you want to go through, history you want to go through to make sure that this is, OA versus rheumatoid arthritis or just, normal aches and pains with aging?
Sure. So, the description of aches and pains in the hands, some back pain, some stiffness in the legs, there's nothing very specific there. So I think one of the key aspects of diagnosing osteoarthritis is getting a really good history. So I would start with really understanding where the symptoms are, having them point to the body parts, having them describe what activities bring on the symptoms, if any activities bring on the symptoms, versus whether or not the symptoms are there persistently, regardless of activity. This is a 67-year-old woman, and so other than the back pain, having complaints in the hands and legs should still bring up a broad differential, including inflammatory arthritis such as rheumatoid arthritis. And so you would want to find out about any inflammatory symptoms, such as, classically we ask about morning stiffness, joint swelling, pain improving with use of the joint, etc. And so, getting at some of those will help understand whether or not these are articular symptoms versus more widespread pain that may be non-articular. So, fibromyalgia is something that can also present with multiple body parts that are symptomatic. Otherwise, the history that she gives about not being able to exercise due to pain and weight gain, that's also not very specific for a particular type of arthritis or even musculoskeletal condition, since for many patients, they feel that the pain is preventing them from being active.
Tuhina, this case has a lot going on. Is there like a classic, just like someone walks in and like a classic history or exam that just like screams to me, okay, this is osteoarthritis. I don't need imaging. I don't need any further workup. This is what this is. What would that be? What would that sound like? So
if you gain a story from her regarding her symptoms that indicate, for example, for the legs, that the pain is in the knees or in the hips, or first MTP, something like that, where it is really at least starts with the pain being with weight-bearing activities. So for the knee, for example, pain with walking for a while or climbing stairs, or people who are more active, pain with jogging, skiing, tennis, things like that, where there's more load bearing in the joint, that would be more consistent with a mechanically driven disease like osteoarthritis, as opposed to a description of an hour of morning stiffness, joint swelling, things getting better as a joint is moving. So those are some of the classic differentiators. The physical exam not finding the typical joint distribution of an inflammatory polyarthritis, such as the small joints of the hands and feet. Now, with osteoarthritis, the small joints can be affected, but we wouldn't expect the same type of joint effusions that we would see in rheumatoid arthritis. Osteoarthritis classically involves the DIPs, so the distal interphalangeal joints, but can also involve some of the other hand joints. But the distal interphalangeal joints and the first CMC, or the base of the thumb, are the classic areas of the hand that are typically affected.
So you're saying that inflammatory arthritis, morning stiffness, and we usually set the cutoff around 30 minutes. I know some people sometimes raise it to an hour, and you're saying if they get better with activity, that's suspicious for an inflammatory arthritis, because osteoarthritis generally they're worse with any activities they're doing with the affected joint. Usually, correct. And yes, the standard cutoff is 30 minutes. Now, people with osteoarthritis can have some stiffness in the morning and they can have a gelling phenomenon, but it's usually not prolonged. You had asked about imaging, and so I just wanted to come back to that point. To make a diagnosis of osteoarthritis, you don't need any imaging. And patients will ask their physician, well, don't I need an X-ray? Don't I need an MRI or something like that? But really, osteoarthritis, the diagnosis can be made on the basis of history and physical exam alone. The only reason to get blood tests or imaging is if another thing on the differential diagnosis can't be ruled out on the basis of history and physical exam. And so in those cases, you would be obtaining blood work to rule out, for example, an inflammatory arthritis. You'd be getting imaging to rule out something else. But honestly, plain film x-rays are not necessarily going to rule out anything else for someone who's had a short course of symptoms. And radiographs are insensitive to the earliest stages of osteoarthritis. In addition, there's a so-called structure-symptom discordance in osteoarthritis, wherein some people have a lot of symptoms and very little to show for it on the x-rays, or the x-rays look
terrible and they don't have very many symptoms. So for all of these reasons, there is no compelling reason for obtaining imaging to make a diagnosis of osteoarthritis.
Yeah, the whole imaging discordance thing, we know it exists for the spine, and then as I was reading for this, for knees, like it's pretty, or for knees or just osteoarthritis in general, even if the knee looks bad on the x-ray, like some of those people have no pain, which is just kind of drives us crazy. Because I guess we've talked about this with other things, like people trying to check procalcitonin for infections. Like we just want a test that just tells us, like, is this, is it this or not? Right.
Well, I'm going to get a little nerdy here. And so as an epidemiologist, I really thought about this question a lot. And 10 years ago, I published in BMJ a little study that I did taking the perspective of an epidemiologist where I'm trying to understand, why is there this discordance? And in thinking about the studies that have been done, the way in which to look at the relationship between structure and symptoms is to make sure that you've accounted for all potential confounders for things that cause people to experience pain differently, all those between person differences. So as an example, if I were to punch you, and if I were to punch you, Matthew, and if I were to punch you, Beth, you would experience that differently, even if I punched you both with the same force. So what are those differences between people that make up the total pain experience? And so what I did was I took I studied people who had pain in one knee but no pain in the other knee. And so in that way, any differences in the experience of pain in the given knee should be due to differences at the knee and not, psychological makeup, genetics, et cetera, et cetera. And in doing that, I was able to demonstrate a very strong relationship between structure and symptoms. So what it points out, or what it highlights, is the fact that yes, structure does contribute to symptoms. And you have to really account for all potential confounders, all those between person differences that contribute to the pain experience to see that signal. And so it highlights that pain is very multifactorial, and structure is only but one component of that pain experience for someone with any condition that can be painful.
So I guess I just want to recap, just because there were a lot of questions from social media about the role of imaging and diagnosing and treating, well, not treating, but I guess managing. So just so I'm fully understanding, you don't need imaging to actually make a diagnosis. There are clinical criteria and history. An exam should be enough a lot of the times. If the presentation is somewhat atypical, that might indicate a role for imaging, and that should start with plain film. And then I think I was reading the EULAR recommendations. If you have sort of rapid progression of symptoms, that also might be an indication, but otherwise there's no real reason to get imaging if you have a good story and a good exam that goes along with osteoarthritis. Is that fair to say?
Yeah, I would say that yes, that if the symptoms are typical and if the course is typical, then there's no need for imaging. Now, there could be, some rare instances, such as with rapidly progressive OA, there might be underlying osteonecrosis or some other things that might need different management. But for the vast majority of individuals who are having a typical symptom pattern and course, imaging is not needed. Now, you have to put this into context. There are over 300 million people worldwide who have osteoarthritis, 30 million people in the US, 10 to 15% of populations around the world. So if you're thinking about imaging, that's a lot of people you would have to image just to find these very few instances of something that may be more atypical. And the vast majority of individuals are having typical symptoms and typical courses.
I want to ask about the physical exam specifically. So some things that I had read about, you look for crepitus, you look for sort of pain throughout the range of motion or restricted range of motion, and I guess joint line tenderness or bony enlargement. Is there anything else that you look for, or can you kind of tell us how you would? Let's just start with the knee, since that's the most common. Like what do you look for, if anything else besides the list I kind of just rattled off there?
Yeah, so all of those things that you rattled off are appropriate physical exam approaches. I also look at alignment at the knee. So while they're standing and supine, I also observe them while walking to look to see if they have any thrust in the knee, either what we say varus or valgus thrust. So is the knee sort of bowing inwards or outwards as they're walking, because that indicates some dynamic changes in their alignment that could have important biomechanical implications. I do look for knee effusions because we have traditionally called osteoarthritis a non-inflammatory arthritis, but that is really a misnomer. If you do appropriate physical exam, you will often find small effusions in people with knee osteoarthritis. You can often obtain synovial fluid from people with knee osteoarthritis. And in research studies where MRIs are used, there's a high prevalence of synovitis and effusion on MRIs. So osteoarthritis is not a non-inflammatory arthritis. It's just not as inflammatory as some of the other traditionally considered inflammatory arthritic conditions. And the pathology of that inflammation, of the inflammatory tissue, is very similar to RA, just to a much, much lesser extent. In addition to alignment and effusion, I also look for instability. Well, I elicit a history of whether or not there's any knee buckling, locking, etc. And I do tests on physical exam maneuvers to try to elicit any concerns about instability, meniscal injury, ACL injury in the history. It would also point to a higher risk of osteoarthritis at a younger age. I also look at the joint above and the joints below, because knee osteoarthritis isn't necessarily going to be the only joint involved. So the hip, the ankle, the foot. I also look at foot alignment. Are they do they have flat feet? Are they sort of pronated? Because all of those things can also impact the biomechanics.
Love it.
I might be taking us a little bit out of order here, but I did want to ask, actually speaking to us as from an epidemiologic standpoint, who kind of gets osteoarthritis? What is the phenotype that sort of most typically presents, or can you even categorize that? So for instance, in our patient's case, someone in their 60s who is a BMI would qualify as being overweight. Are there certain characteristics of patients that make osteoarthritis more suspicious than other, I guess, joint pathologies?
Sure. So, just stepping back to what I said a bit earlier, 10 to 15% of adult populations have symptomatic osteoarthritis. So it's a substantial proportion. The risk factors include increasing age, female sex, obesity. So her BMI is 27. At my institution, we often see BMIs above 35 and even above 40.
Yeah.
History of knee injury is, so as I was mentioning, meniscus, ACL, et cetera, that's also a major risk factor. There are some genetic associations that have been identified in genome-wide association studies. There's other biomechanical things such as leg length discrepancy. If you have a pre-existing joint damage due to other things, for example, rheumatoid arthritis, that joint will be more predisposed to having osteoarthritis. And then there are a whole host of other potential risk factors that have been studied epidemiologically, but none that have definitively been demonstrated, across the board, or have had intervention trials targeting those risk factors showing a benefit. So there's still a lot to learn in osteoarthritis.
I want to ask you a little bit about, you sort of hinted to it here. Can you tell us what are we understanding now? Because this is a big thing, and maybe you could tell us about how you would explain it to a patient. So what's like, let's say we were going to diagnose our 67-year-old female here without a name, which I'm very disappointed about, Beth. But let's say we were going to diagnose her with osteoarthritis. What might you explain to her? What is that, and what causes it? And maybe kind of put it in terms that we could then repeat to our patients in clinic tomorrow when we're seeing them.
Right. So I think first is addressing some misconceptions about osteoarthritis. It's not just a disease of wear and tear. It's not just something that happens naturally with aging. I think there is this conception that it's a part of normal aging, and it's not. It is a disease, and it's largely biomechanically driven, wherein the catabolic activity in the joint is outpacing the anabolic or sort of healing mechanisms in the joint, so that whatever the inciting event may be, there are a whole host of molecular pathways that are activated that can lead to degradation of cartilage, bone marrow lesions, synovitis and effusion. So a whole host of things that can be occurring that for which the anabolic mechanisms can't keep up. And that manifests itself then as joint space narrowing, which we can see on imaging, which at a tissue level is loss of cartilage, is minuscule extrusion or tears. There's also bone shape changes, and so those can also result in apparent joint space narrowing. The development of more bony prominence is related to osteophyte formation, which is one of the biologic responses of hypertrophic chondrocytes. They undergo endochondral ossification and develop osteophytes. So there's a whole host of things that are going on at the joint level. So this is not just a disease of cartilage. It's not just a disease of cartilage and bone. It's a disease of the whole joint. And I think if we were to name this disease today, this would be like total joint failure. So, just like we talk about congestive heart failure or renal failure, this is not a single tissue. It is a, whole organ failure.
There's 2 articles written by a doctor, it's a Dr. DJ Hunter from Australia. It's a seminar paper in Lancet 2019, and figure 2 in that has like a really great summary of what you were just talking about, kind of a picture of like the synovium, the cartilage, and the bone, and all these sort of inflammatory changes and remodeling changes that are going on, and as you said, total joint failure, which is just it's not the way that it was taught when I was in medical school. So it's
right. Well, I'm glad you gave DJ a shout out because he's a friend of mine and we used to work together. So the osteoarthritis research community is, very well attuned to this way of thinking, but it hasn't really been taken up by the sort of larger medical community.
Well, I think this is going to help.
I mean, it's a little bit encouraging. I know I keep driving us out of order, but because I feel like if you view it as wear and tear, then progression is kind of inevitability. If you're talking about it in terms of inflammation and molecular targets, then you're looking at ways you can actually maybe even modify progression of disease. So presumably that's something that's being looked at, or are there things coming down the pike that actually can help modify the natural history?
Yeah, absolutely. So as you know, there are currently no treatments on the market that are proven to alter the structural progression or prevent the disease. So really, our approaches to OA management are to try to ameliorate symptoms and hopefully prevent progression by addressing things like joint protection, reducing weight, being physically active, etc. But given the vast amounts of information being understood about OA pathophysiology, there are a whole host of targets that are being tested, and even currently in phase 1, 2, and 3 trials, targeting various molecular mechanisms in osteoarthritis. And in addition to the structural targets, there are also unique pain targets. And, I think one of the challenges in osteoarthritis is that it is a slowly progressive disease. And so if you are targeting a single mechanism, to demonstrate symptom benefit, it could potentially take a long time. So that's one of the challenges trials have been facing to date, is how do you show the direct link between structural improvement and symptomatic benefit if there's a lag between the two. But it is an exciting time for osteoarthritis because there are a lot of promising targets that are being developed.
You think we're looking at kind of both preventive agents and disease modifying agents for osteoarthritis in the future? Is there a future 10 years from now where maybe that will be the case?
Yeah, I think so. I think many of the targets would be suitable both for treating structural abnormalities and preventing. And some of them would make more sense to institute at an earlier phase before you have this whole cascade and you've gone beyond the point of no return. And I think some others, there are challenges because, to expect a single molecular target to overcome someone's BMI of 47, going through that joint is a lot to ask for poor little molecular target.
Yeah.
So, so I think we have a lot of work that we need to do with our patients. And I think just, generally society as a whole, because this isn't just about osteoarthritis. I've done some work with some colleagues where, really thinking on a societal level and social determinants of health is where we need to be because the weight and knee injury issues that might be occurring in childhood and adolescence is something that by the time they come to see us in their 60s is probably, too far out the gate.
Right. And you bring those up because as of right now, I mean, those are the two preventive measures, right? Preventing joint injuries and then preventing, weight gain to the point where the joint is loaded excessively. Those, as of right now, as far as I know, those are the only two preventive measures we have.
Yes. Yeah. Those are the ones that are best supported by evidence. Yes.
I think we should move on and talk a little bit about pain, and then that will, I think, naturally bring us into how the treatment's done. What is the model that you use to think about how pain is caused in osteoarthritis? And is it all nociceptive pain, or do you believe that there's other types of pain mixed in there as well?
Yeah, so this is a very hot topic in osteoarthritis. What I would say is that without the peripheral pathology, the actual pathology of osteoarthritis, we wouldn't have the disease, the symptomatic, the symptomatic expression of that disease. So there has to be some role of nociceptive input. And in research settings, MRIs have demonstrated that bone marrow lesions and synovitis effusion are among the most consistently associated pathologic features with pain. But beyond that, there is a point where that ongoing peripheral nociceptive drive likely leads to peripheral sensitization and or central sensitization, wherein the ascending nociceptive signals are facilitated. So they're either the nociceptors are responding to to signals that they normally wouldn't be responding to, stimuli that may be non-noxious, or they are just firing more than they should be. And so the signaling going up to the brain may be augmented. And so I think we don't have any clinical tools at present to be able to really understand what pain mechanisms are at play in a given individual. There are some research tools, and we've demonstrated that people who have evidence of pain sensitization, either peripherally or centrally, have more pain severity. They also tend to do worse after joint replacement, and they are more likely to be the ones that transition from having intermittent activity-related pain to more persistent pain that's there regardless of what activity they're doing.
Is that how you identify them clinically, like patients that they have pain like out of proportion to what you'd expect based on their joint damage, and they have pain at times when they're not even active?
Yeah, so as I said, we don't have bedside tools that can help us really figure out these the mechanism behind someone's pain.
Okay.
So I do a really comprehensive evaluation of things like their sleep, their mood, do they have widespread pain? Are they having pain in non-articular areas? Do they have a lot of tender points? So is there like a fibromyalgia component?
Yeah.
And I also think that there's a concept of stage of pain that's distinct from, or could be distinct from, stage of pathologic disease. And so someone could have the same level of pathologic disease, but one person is sensitized and the other person is not, and that might be why they have more pain severity. And as the peripheral nociceptive drivers remain, for some people, that sensitization may be occurring earlier than others. Some people might have predisposition to be sensitized. We don't know enough yet about why some people experience more pain than others. In relation to why some people are sensitized, develop pain sensitization, and also how to figure out what are all of these other contributors to their pain, such as I was mentioning, depressive symptoms, poor sleep, people who are pain catastrophizers and have poor coping skills. So there's a whole host of things that we have to take into account. And this is not just in osteoarthritis. This is in any pain condition, even though we're not talking about rheumatoid arthritis today, but I'll just say that sometimes with the treat to target approach to rheumatoid arthritis treatment, that if if they have a high disease activity, we need to up their DMARDs, continue to increase the dose until we get the disease under control. Well, if a large part of the disease activity seems to be pain and articular pain and not much swelling, some of that might be pain sensitization. And we shouldn't be pushing the DMARDs. We should be trying to figure out what other aspects are contributing to their pain.
We did a episode on back pain a long while back, and we talked about these yellow flags. And some of those were, people coming in, people that catastrophize their pain, people that have a history of like just failing multiple therapies already. And it seems like you're kind of hitting on some of these same things here as you're talking about this. So it's kind of like you got to take into account the whole patient, not just what's going on at the joint, because and that's going to come into the treatments that we're going to talk about here. So the first question I want to just ask is there was 2012 guidelines from the American College of Rheumatology, and they talked about knee, hand, and hip osteoarthritis because those are the three most common types, from my understanding. So what modalities should pretty much everybody be getting if they have those things? And then we can talk about, we have a lot of questions about some of the fringe therapies as well. So what's kind of like should be the main armamentarium of treatment for the three main types, knee, hand, and hip?
Sure. So just for full disclosure, I'm in the steering committee leading the update for the ACR treatment guidelines, so you can have me back when they're published. Yeah. So I'm going to stick with what has been published. So the mainstays of OA management, regardless of which joint site, is education about the disease, self-management, exercise, weight loss, physical therapy. For hand, occupational therapy may be appropriate as well. So largely addressing biomechanical aspects of the disease. I should mention that obesity, it has an association with, for example, hand OA. And so there is also a thought that there's systemic effects of circulating adipokines, et cetera, that could be contributing to pain as well. Patients, as you know, patients often want to have a pill to manage their diseases, their complaints. So a challenge with osteoarthritis is really having the patient understand that a lot of the management of osteoarthritis is things that they need to do themselves. And I often will, write a prescription. I send them to weight and nutrition management. And this morning on NPR, there was actually a really nice segment from the Osteoarthritis Action Alliance talking about exercise. And for many patients, they think you're crazy. I'm in pain. and now you want me to start an exercise program. Well, I don't even talk about the word exercise. I just start by talking about walking, because they don't need to do high impact aerobics and not your blazing jump rope or whatever you were mentioning earlier.
It was a ballistic jump rope.
Oh, sorry, ballistic. Okay. So,
hoping for a sponsorship.
So, anyone should be able to start a walking regimen. And trials have shown that, simple walking programs with some strength training actually does have a very meaningful improvement in pain. I think one of the challenges is how do we help someone start that walking program when they're currently in pain? So I spend a lot of my time just on walking and weight loss, nutrition, etc., as one of the first mainstays. If a joint like the knee or the hand is symptomatic, we might start with something topical, like topical Nsaids or topical capsaicin. And topical capsaicin, capsaicin is the active ingredient in hot chili peppers. So if you've ever eaten a hot chili pepper, it burns your mouth, it burns your tongue. And that burning sensation is, like I explain it to patients, it's like it's drawing out the pain chemicals from your nerve terminals. And once those pain chemicals are drawn out of your nerve terminals, then you get some numbness. Then you get like pain, sort of pain relief. So it has to be applied multiple times. So topical capsaicin has some downsides in that it can cause some burning on the skin, has to be applied multiple times, but at least helps avoid needing systemic therapy.
And tell them not to rub their eyes, right?
Exactly. Wash your hands immediately. Yes. Acetaminophen has been considered sort of a first-line therapy. Osteoarthritis Research Society International has recently published treatment guidelines, and there's been a number of meta-analyses demonstrating that acetaminophen has really minimal efficacy. But, we have a lot of patients who cannot take NSAIDs. And so I still think it's reasonable to try acetaminophen, but sort of knowing that the efficacy is likely to be limited. But I also try to be positive for my patients without crossing the line to being unethical and lying. But I do like to give them hope. And this is like probably a podcast for another day where, I think we need to harness the placebo effect, and particularly for diseases where we don't have a lot of easy options. I think provider communication and that therapeutic alliance is really important to harness. So moving on to oral NSAIDs, a lot of our patients are older. They have cardiovascular disease, as I think your case one had some family history of cardiovascular disease or something like that. They have renal issues, they have GI issues. So oral NSAIDs can be challenging. Rheumatologists often use intra-articular steroid injections. There's some controversy about its efficacy in light of a trial that was published in JAMA in 2017. But other trials have shown short-term benefit, whereas that trial did not show any long-term benefit. So, for some patients, getting 2 or 3 months of benefit is worth it if they can get even that short duration of benefit.
I think it's funny that I think it's the same trial. That was the cartilage loss one.
Yes.
It was like 0.2 millimeters cartilage loss versus 0.1 millimeter cartilage loss. And it's like, clinically, no one knows if that even matters or not.
Exactly. It was like a less than a voxel on the MRI of a difference. And, for that rate of cartilage loss over several years, when you start off with, for example, 4 or 5 millimeters of cartilage, when you don't have anything else to offer an individual, that, and again, we don't know what the clinical significance of that is. So I think the jury is still out about how worried we should be about that. But I do think it highlights that we shouldn't be doing injections too frequently, and that, some of these approaches that we use that have been, decades old approaches, that we still have more to learn about all the effects.
Beth, we had more questions from social about injections.
Yeah, I mean, there was like general questions kind of about the glucocorticoid injections. And then there was one person who asked about hyaluronic acid injections as a pain relief.
Yeah. So, I was about to go down that road as well. I think this is one of the most controversial topics in osteoarthritis management. There are a lot of trials that show benefit, but in meta-analyses where they've looked at industry sponsorship of trials and limited analyses to studies with low risk of bias, the efficacy is small. In fact, one meta-analysis where they limited it to non-industry sponsored trials that were that had low risk of bias, the effect size was close to null. Having said that, the ORZ treatment guidelines that were recently published did acknowledge that intraarticular hyaluronic acid injections are of unclear benefit, but that in individuals with comorbidities where other therapies might not be appropriate, that you might consider hyaluronic acid injections. And for those patients who are really end-stage disease and the next step is joint replacement, but they're not a good candidate, this might be something that you try in those patients. So it's not a great answer as to whether or not one should use hyaluronic acid. I think it just reflects the challenges in the data.
I just wanted to kind of recap injections in general with corticosteroids. The cartilage loss thing, jury's still out, but it wasn't so worrisome that we should stop those altogether. It seems like the long-term benefit of those is uncertain, but maybe in the short term, like the first 3 months or so, maybe that's when patients might, if they're going to have benefit, they might see benefit. And I was reading that maybe patients with like the most severe disease most severe or evidence of inflammation, they might actually benefit from them. Is there any way to select those patients other than that?
So it's been the presence of inflammation as evidenced by effusion or synovitis on ultrasound, for example. Many rheumatologists do bedside musculoskeletal ultrasound. It was thought that those people would be the ones that would be most likely to respond. The JAMA trial that we were just mentioning, they did select individuals based on presence of effusion or synovitis on ultrasound. They didn't find any long-term benefit, but that doesn't necessarily mean that they might be more likely to have short-term benefit. There is now a long-acting intraarticular steroid formulation available, but at least as of this present data that's available, published, it seems to be similar to the regular formulation that's available. Its one benefit is that it has less of a blood glucose effect than the typical formulations of intraarticular steroids.
Before we get into some of the more non-traditional modalities, I had a couple of specific questions, if you don't mind. I know the 2012 ACR recommendations talk about occupational therapy for hand OA, which it makes perfect sense. I don't think I've ever made that referral. Who's the appropriate patient for that, and how often does that happen in practicality?
Right. So, I think part of the challenge there is that there haven't been enough studies of occupational therapy for hand osteoarthritis, in contrast to a number of well-conducted studies for physical therapy for knee or hip osteoarthritis. So types of things that occupational therapists do include sort of specific hand exercises, paraffin therapy, certain, like for example, certain orthotics, like for CMC joint. They also do some kinesiotaping. So there's a number of modalities that an occupational therapist can do. I think it highlights a research agenda where there's a gap in high quality trials to really make strong recommendations.
And the other question I had in terms of Nsaids selection, I don't think the guidelines get too specific as to what to choose, but I guess, do you personally have a preferred Nsaid that you like to use?
The first step would be to consider which joints are affected and how many joints are affected. If it's one or two joints or just a few joints that might be amenable to topical therapy, that would be the first line choice over using systemic therapy. So for example, if it's one or two knee joints or a few hand joints, then topical therapy would be preferred. The hip joints are not amenable to topical therapy. The two main topical therapy options are topical Nsaids and topical capsaicin. Topical Nsaids can be used in individuals who otherwise have contraindications to systemic Nsaids, since there is very little systemic absorption. But when there are more joints involved, or more persistent symptoms that are otherwise not amenable to or not responsive to these first-line options, then one might consider systemic therapy, such as with oral Nsaids. When it comes to oral Nsaids, ibuprofen and naproxen are the most commonly used Nsaids. There are no real good head-to-head trials to give us direction as to which Nsaid is the most efficacious. But a recent meta-analysis from the Lancet a couple of years ago now demonstrated that diclofenac had a worse safety profile than other Nsaids, and therefore diclofenac should be considered as a non-preferred Nsaid in the management of osteoarthritis. As for other options, celecoxib was shown in a trial a couple of years ago to have a favorable safety profile and therefore can also be considered. Overall, I think the choice of NSAID has to take into account cardiovascular, GI, and renal issues, safety issues, as well as patient's prior response to an NSAID and convenience of dosing. Some patients don't take an adequate dose or don't take the medication at the appropriate frequency, and therefore NSAID failures may not be necessarily a reflection of the NSAID itself not working properly for the patient, but rather that the patient was not taking the dose in an effective manner. And patients also need to be educated about other over-the-counter agents that may also contain NSAIDs so that they're not accidentally doubling up on NSAIDs and increasing their risk of adverse effects from NSAIDs.
Thank you.
Are you using much of the SNRIs like Duloxetine? It seemed like that might have some evidence behind it, at least modest benefit.
Yeah, so there was an actual trial done in osteoarthritis with Duloxetine, and it was positive. It was a small trial, and there were some concerns about it. But I think one of the clinical challenges with Duloxetine is tolerability. But certainly, if I think that someone has depressive symptoms, sleep issues, widespread pain issues, those might be the individuals where I think about using something like Duloxetine.
Okay, Beth, you want to take us down the rabbit hole and see what did some of our Twitter listeners? I thought I saw some weird questions on there.
Well, we had a lot of interest about some alternative therapies that people might be using or could be using related to CBD. Whether in an oil form that's applied to the joint or sort of taking edible items that have CBD. There's a few questions about using marijuana as well, and also turmeric. So we just wanted to sort of get your take on some of these ideas. Sure.
So CBD and the like, marijuana, et cetera, has been a strong area of interest in pain research, and including studies in animal models for osteoarthritis and in humans. And the CBD1, CBD2 receptor studies that I can think of, and I won't try to remember all the different enzyme names like FAH or something like that, those trials have not been positive in OA. And I think there's still a lot to understand and learn about CBD products. And so while it might make sense to a certain degree, pathophysiologically, I think a lot more study needs to be done. Other things like turmeric. So turmeric does actually bind to a receptor on to binds to nociceptors. And so there is a theoretical reason why that might be beneficial and supposed to have some anti-inflammatory effects. But what dose, how often, all those things are unclear. There's some cultures where they will rub turmeric in mustard oil on their joint, which is a messy, smelly affair. But for someone, some of your listeners who think that their patient might want to go out to the health food store and get some supplements, it's really unclear what dose, if it works. Trials have not been done well. And as you know, supplements are not well regulated, so you don't even know how much you're really getting. I would say some other therapies that have shown a little more promise, and maybe not to the point yet where they're proven in trials, but fish oil, omega-3 fatty acids, that has some promise. The issue is that people need to take a much higher dose to get an anti-inflammatory effect than you might otherwise normally take. But there's been a few promising suggestive signals in a few different studies, including other arthritis conditions like rheumatoid arthritis.
The glucosamine chondroitin story, I've seen lots of negative trials. I think there was a chondroitin sulfate trial. It was like 800 mil. It was like a pharmacologic grade chondroitin sulfate, and they showed maybe there was benefit, but everything else I've seen about glucosamine chondroitin has just been like, doesn't work. What do you tell patients when they ask you?
Yeah, so again, just going back to the evidence, similar to the hyaluronic acid story, there are lots of positive trials, but when meta-analyses are performed and they're limited to non-industry sponsored trials, the effect sizes are quite small and close to the null. The glucosamine sulfate is a sort of proprietary brand made by a particular company, but glucosamine hydrochloride has been studied in non-industry trials. There's no reason once glucosamine sulfate or glucosamine hydrochloride gets into your stomach and is metabolized that they should behave any differently. The salt dissociates, and so the well-conducted low-bias trials really show no efficacy. And an NIH trial, the GATE trial years ago, demonstrated that there was no benefit. Chondroitin, there was a trial recently in hand osteoarthritis that seems to be well conducted, and that there was a positive benefit on symptoms. So so maybe there is something there, but at least for knee and hip and for glucosamine, there hasn't been enough convincing evidence from non-industry sponsored trials of low bias.
Was that over-the-counter chondroitin in that hand trial, or was it like a pharmacologic grade?
From what I remember, it was a pharmaceutical grade chondroitin. Mm-hmm. But what I do say to patients when they ask me is the biggest side effect is on your wallet. So if you want to try it, and then again, sort of the philosophy of harnessing the placebo effect, like if they have some benefit from it, and there's low side effects, it may not be harmful, but it's certainly not something I encourage. The same could be said about, for example, acupuncture, where there's a lot of controversy about its efficacy. Trials are really challenging to interpret because you don't know how adequate the sham control is. But again, we, at least as long as people are using sterilized needles, we don't know of any adverse effects of acupuncture, and so other than cost or insurance coverage, etc. So if someone wants to try it, I don't discourage it.
And where do things like yoga and Tai Chi fall on the evidence spectrum?
Yeah, so Tai Chi has actually had some randomized trials in fibromyalgia and osteoarthritis and has been demonstrated to be efficacious. Now, some could quibble about whether the control group was adequate, but I think for things like Tai Chi, yoga, those mind-body practices where there's really little downside, as long as they're done safely and the instructor is well trained, and they, for example, someone with hip OA has to be careful about certain yoga positions, etc. There's no downside to it. Similarly, meditation. I recommend meditation all the time to my patients. I might not sell it as meditation. I think in Western culture, it's more acceptable these days to talk about mindfulness and mindfulness-based stress reduction. So the American College of Physicians Management of Low Back Pain recommends mindfulness-based stress reduction. There's no reason to think that the trials of MBSR in back pain should be any different for any other pain condition, and that could help our patients with sleep, depressive symptoms, anxiety, catastrophizing, coping skills, etc. There are lots of free apps. And my patients who have been doing this mindfulness stuff, it's really funny, like just their personality improves when you see them next. So again, I can't say that there have been definitive trials in osteoarthritis, but when we are struggling with offering something to our patients, I do try to look for these types of things that would have little downside and potential benefit.
Is there a specific mindfulness app that you like or recommend for your patients?
Well, for patients that can afford to pay for a subscription, Headspace has some good programs. A free app that my colleague who does research in mindfulness-based stress reduction and has used in her trials is Insight Timer, INSIGHT, and that has a number of programs and it's free.
Yeah, I've used both. They're both great. The Headspace, I think the first 10, it has 10 free sessions on there that you can get. It kind of teaches you how to do it. It's definitely useful.
I think it took me about 2 years of not actually doing it before I canceled my subscription. That's why so I'm looking for free resources now. So that's helpful.
I think there's at least one medical group that if you're a member of it too, if you're like a physician or medical student, you can get free access to Headspace.
Oh, okay.
Yeah.
That's good.
And some institutions have it as an employee benefit.
Excellent.
We busted our time here with you, so we got to let you go at some point. Get on with your night, and I wanted to just ask for some take-home points. If you wanted to just, I would like to just give some hope and just briefly mention that there are some new targets that are out there, and I know we kind of briefly mentioned this, but I would like to just sort of end with something hopeful. And the sort of most promising one was sort of what we talked about in the beginning, these anti-nerve growth factors that I think will really revolutionize pain management. All right, fantastic. They can't come soon enough. Can you give the audience, since we've taken so much of your time, can you give the audience some of your take-home points, and then we'll let you go? I'm sure you're sick of our questions by now.
No, not at all. So I think when examining or, when faced with a patient who has some musculoskeletal pain complaints, just, bear in mind that joint pain and musculoskeletal pain are the number one reason why people are coming to see their physicians, and not all of those complaints are an arthritis. So really try to understand where in the body the pain is occurring. And if there are no concerning signs for an inflammatory arthritis or systemic autoimmune disease, and if the story is consistent with osteoarthritis, then the first steps would be management with advice regarding a walking program, weight loss, helping the patient maybe get into weight and nutrition management, sending to physical therapy. Physicians really underutilize physical therapy, and they really are first-line management partners in managing osteoarthritis.
And did you have anything that you would like to plug to the audience before we sign off here?
Oh, man. Well, so stay tuned for the ACR osteoarthritis treatment guidelines. Also, stay tuned for the ACR gout treatment guidelines, which I'm also leading. And check me out on Twitter, see what I have to say.
Fantastic. Yeah, I can't wait. I can't wait for all these guidelines that you're going to be. We'll have to. Maybe we can just. We'll have to figure something out. So when they come out, you think they'll come out in 2020?
Yes.
Okay. So when they come out, send us an email and we can figure something out. We can have you back on and do like a 2.0, gout 2.0 and osteoarthritis 2.0. We could talk about some, whatever loose ends need to be tied up from both of those episodes.
Sounds good.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Strong word. Get your show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on iTunes, or contact us at thecurbsiders@gmail.com, or reach out on Facebook, Instagram, or on Twitter at thecurbsiders. I weirdly now have to thank myself, Beth Garbs-Garbatelli, and also a big thanks to our social media team. Hannah R. Abrams runs our Twitter. Chris Chu-Man-Chu is on Facebook, and I'm running the Instagram. Until next time, I've been Stuart Brigham.
Oh, poor Stuart. Not here tonight. I've been Matthew Frank Watto.
And I remain Dr. Paul Nelson Williams. Thank you and goodbye.
And I think Beth didn't really sign off, but that's okay.
I'm a doctor.
I wish to God we could leave that in.